And now, I am pleased to introduce Dr. Christen Kerr on presenting Dementia and Depression. There is help out there.
Good evening. Hi, I'm Dr. Christen Kerr. I am a psychiatrist from McLean. I've been practicing in McLean for 25 years. Hello. Wait a sec. Let's get back. There we go. Hi. Sorry about that. I've been practicing in McLean for 25 years. I am board certified in adult and geriatric psychiatry. And I'm going to talk to you tonight about some issues in some psychiatric issues in the elderly. I don't have any disclosures. I don't take money from any drug companies or any research grants. And I'm going to be talking to you about off-label use of medications. And off-label use of medications is when medications are used for purposes other than purposes for which they're FDA approved. So let's get started. I'm going to, because of time limitations, I can't talk about every diagnosis. So I'm going to talk about, I'm going to use depression and dementia as examples of the psychiatric issues. And I'm going to start with talking about when it's appropriate to ask for a consultation. I'll go then to depression, diagnosis and treatment. And then I'm going to go to dementia, and the medical term for dementia is neurocognitive disorder. So I'll be using dementia and neurocognitive disorder interchangeably. I'll talk about diagnosis and treatment of neurocognitive disorder, and then I'm going to talk about benefits of treatment, why it's important to treat, and I'll finish up with family and caregiver involvement. Now, we're emerging from the global pandemic, and I'm hard pressed to think of anyone who has not been affected by it. I'm hoping that you're getting some relief with vaccinations and the warm weather and feeling a bit better. I know I am, and I hope you are too. But when we look back on it, it was a time where many of us felt isolated. We didn't have the usual opportunities for relaxation, recharging. We were isolated from our friends and families. People were anxious about their health and safety and the health and safety of their loved ones. And it was a difficult time. It was pretty natural for us to feel lonely, sad, anxious. Maybe we were eating more than usual, drinking more alcohol than usual, maybe exercising less, and feeling perhaps like the woman in this next slide. So there we were, looking for where's the zest in life and feeling kind of down. So when does feeling sad or blue, when does that become the kind of depression that warrants a psychiatric evaluation? And maybe perhaps we can go to the next slide, please. So a couple of guidelines for that is when symptoms interfere with functioning, either social or occupational functioning or activities of daily living, or when the symptoms present a significant change from baseline. Next slide, please. Thank you. So this is the American Psychiatric Association Diagnostic and Statistical Manual's definition for the diagnostic criteria for major depressive disorder in adults. And the first symptom there, of course, is depressed mood or loss of pleasure, loss of zest for life, for at least 2 weeks, and there is your change in functioning. And then 5 of the symptoms off of that list: depressed mood most of the day, loss of interest or pleasure, weight loss or gain, eating more or eating less, insomnia or hypersomnia, psychomotor agitation or retardation. That can be the lethargy, not moving, not getting out of bed, or it can be psychomotor restlessness, agitation, pacing. fatigue, feeling worthless or excessive guilt, or thoughts of suicide or death. Now, in the elderly, depression can manifest in some different ways that are not covered in this diagnostic criteria for adults that I want to mention that can be important. They can be kind of subtle, such as non-compliance with medical treatment or with medications, somatic symptoms such as pain, headaches, chest pain, abdominal pain, muscle tension, nausea, indigestion, or various types of physical complaints. And then there's another kind of depression that is unique to this age group that I call it kind of an existential dissatisfaction with life. And let's go to the next slide. And I want to talk to you about Erik Erikson's stages of development. And you may have seen this before. Erik Erikson said that for each phase of life, there is a task. And, for infants, they have to master trust. Young children, autonomy, and, older children, initiative, and so on. I mean, you can see for yourself there. But for 65 and older, in the later years, he described ego integrity versus despair. And, I've certainly seen this quite a lot in my experience. Older people tend to look back over their lives and reminisce, take inventory, think about the experiences they've had, the decisions they've made, maybe the hurdles they've overcome, and kind of pull it all together. And maybe they think that they're satisfied with what they see and they have come to some peace of mind, or they're dissatisfied and they come to some sense of disappointment or despair. And that may lead to a kind of depression that may not fit into that diagnostic checklist, but nevertheless, it can be significant and is worth addressing in treatment. So that's a sort of a variant that I wanted to describe. And so next slide, please. So what about treatment? Next slide, thanks. And this is kind of a busy slide, and I don't expect you to remember all of this or, memorize it or anything like that, but I just wanted to give you a feel for the kinds of treatments that are available. There is help out there. I only listed the psychotherapies that are evidence-based therapies. These are therapies that have a double-blind, placebo-controlled trials to support their efficacy. Cognitive behavioral therapy is very strongly supported by research evidence. Interpersonal therapy and problem-solving therapy as well in the geriatric population. But there are a number of other psychotherapies, talking therapies, that can be very helpful. Psychodynamic psychotherapy is that's sort of the older style therapy based on psychoanalytic principles, and folks often find that very helpful. It's not as well documented, but it can be quite useful. Certainly group therapy, day programs, and a number of other therapies as well. But these are the three that have the strongest evidence support. Then we have medications. The SSRIs are selective serotonin reuptake inhibitors. That's the Prozac group. I'm sure you're familiar with those household words: Prozac, Zoloft, Paxil. The SNRIs are the serotonergic, noradrenergic reuptake inhibitors, with the probably most popular examples being Cymbalta and Effexor. I'm using the trade names because they're more easily recognized. And then we have the of the others. I'm not going to go through each one, but the dopamine blockers are lithium, thyroid, and dopamine blockers are augmentation strategies, and the dopamine blockers would be the Abilify, Seroquel, Latuda that you probably see advertised on television. Neuromodulation is the third category, and that's electroconvulsive therapy, which has, there's significant stigma associated with electroconvulsive therapy, but it is 40 or 50 years old. It has been around for a long time, and it is the safest, the most effective, and the fastest treatment we have. It's extremely effective, and there is some potential for some temporary and potentially some permanent memory loss. So it is pretty invasive. It is done in a hospital setting, and it requires general anesthesia. So it's pretty invasive. It's usually done 2 to 3 times a week, but it's usually pretty fast, works pretty quickly. So because of those issues, we now have transcranial magnetic stimulation, which I call it ECT light. It's less voltage. It's electrical stimulation, but it's produced by magnets, and it has a much more favorable side effect profile. There's no memory loss, and there's no general anesthesia. Patients can drive themselves to the treatments and drive themselves home. It's very user-friendly. It is, because it's lower voltage, it takes longer. So the biggest issue with it is that it's time-consuming. It's 5 days a week for 5 weeks. So it's a pretty big time commitment, but it's a very interesting treatment. It's completely different from psychotherapy, which is talking therapy, medication, which is chemical. This is electrical. And I think we're going to be seeing a lot more neuromodulation coming down the pike, different ways to administer electrical stimulation, because it is so effective. So anyway, and I think we're going to be seeing more medications coming down the pike too. So definitely promising. Depression is quite treatable, so it's important to address it. So next slide, please. So on to neurocognitive disorder. Next slide, please. This is just to give you the trajectory. On the left, you see, this is what people talk about as they get older, having more trouble remembering names, walking in the kitchen and forgetting what they went in there to get, but not that it doesn't really affect anything, and most people, no one else would notice but them. That's the far left. In the middle is mild cognitive impairment. That would be cognitive changes that maybe the patient notices, maybe the family will notice, but does not affect functioning. This is our, the criteria I mentioned at the beginning, affecting functioning or change from baseline. There's no significant, no impairment in functioning. Mild cognitive impairment affects 12 to 18% of the population over 65. And mild cognitive impairment converts to dementia 10% a year. And then on the right, you see the dementia, which is interferes with everyday abilities. So there's your functioning issue. So next slide, please. Now, this is again the American Psychiatric Association Diagnostic and Statistical Manual definition for major neurocognitive disorder. And it's evidence of significant cognitive decline from a previous level of performance. So there's your change from baseline in one or more cognitive domains, and it lists the domains that might be affected, and you can read those for yourself. I'm not going to read those for you, but and then so it's change from baseline, and then the second criteria there is interferes with functioning. The third one is the deficits don't occur in the context of delirium. That's a way of saying it's not secondary to a medical problem. It's a particular type of medical problem, but that means that it's a neurodegenerative cause and not secondary to another medical problem. And the fourth criteria is not secondary to a mental disorder. So it's not secondary to depression, anxiety, some of these other things that can have symptoms of some memory problems associated with the actual psychiatric diagnosis. So go to the next one. Now, dementia is an overarching umbrella term that encompasses a number of diseases or disorders. So dementia is a sort of catch-all for these, and I listed a few of them. This is not an exhaustive list. There are some other causes of dementia, but I just put in some of the main ones, with Alzheimer's disease being by far the most common cause, 60 to 80%. Vascular dementia, 10 to 15%, with mixed Alzheimer's and vascular, 30 to 50%. Then we have Lewy body dementia and frontotemporal dementia making up most of the remainder. And then we have, a few others, Parkinson's disease, which is associated with dementia, alcohol-related dementia, traumatic brain injury, which we're learning can cause memory deficits, and then other miscellaneous normal pressure hydrocephalus, autoimmune disorders like lupus, and Huntington's disease, which is a genetic inherited movement disorder associated with memory loss. Go to the next slide, please. Thank you. So, diagnosis. Next slide. Thank you. Now, evaluation. Evaluation is important both to try to clarify what type of dementia is present, as well as to diagnose any other disorders that may be contributing to the memory problems. So a physical exam is the first place to start, to look for things like movement disorders, neurologic signs, a laboratory workup. You want to find anything that's reversible, any kind of reversible causes, vitamin deficiencies like the B12, the folate, the vitamin D, thyroid disease can cause memory problems, urinary tract infection, any of the infectious urinalysis for urinary tract infection, HIV, the VDRL is for central nervous system syphilis, and the Restogram sedimentation rate is a screening tool for autoimmune disorders. Whenever I see somebody and I'm working them up for dementia, I always do a medication review. Medication side effect is a significant cause of memory compromise in elderly patients. There are the list of medications that can cause memory problems in older folks is very long. I can tell you some of the big offenders, the four biggies, well, five, I guess. The four biggies are steroids, anticholinergics, and anticholinergics, the prototype being Benadryl. Benadryl is anticholinergic, and I've seen many people with either memory problems, sedation, even hallucinations from Benadryl. And then some of the antidepressants that were actually on that list are anticholinergic, so we have to use those with caution, especially in someone with dementia. Benzodiazepines, and again, I'll use the trade names on this because you might be more likely to recognize them, but the benzodiazepines are sedative hypnotics like Klonopin, Ativan, Xanax, Librium, Valium. Those can cause memory problems. And then beta blockers, Inderol, metoprolol. They're antihypertensives. Antihypertensives are beta blockers. And then the fifth one I sort of throw in there is opiates. Opiates are quite, can be tough when it comes to memory, and can cause depression as well. So medication review, screening for depression, anxiety, and substance abuse, because as you saw in that fourth criteria, some psychiatric disorders are associated with memory loss. A sleep study for obstructive sleep apnea is real important. Sleep deprivation causes memory loss. I mean, it can cause mood symptoms also, but it's usually through poor concentration, but it really impairs concentration and memory. So sleep apnea is very important, not just because it causes hypertension, but also because it causes memory problems. Brain imaging is useful, and I mean, we can talk more about brain imaging in the Q&A if you would like to, because there are a number of different strategies for that, but usually an MRI or a CT scan is part of a routine workup. And then psychometric testing, which is paper and pencil testing that will map out cognitive deficits and can help clarify the diagnosis. Next slide, please. So treatment. The medications for the core memory symptoms are the acetylcholinesterase inhibitors. Those are things like donepezil, ribostigmine, galantamine, and tacrin. Those are the acetylcholinesterase inhibitors. They have a modest effect. They're not real robust, but they can, if they may only make a few different, a few points difference on a memory test, but if it changes functioning, it can make the difference between someone, needing help or not needing help. If they function a little bit better, that can make a significant difference. And then memantine is also treats the core symptoms of memory, but it works by a different mechanism, so I put it in a different category. Caprilidine is a therapeutic food, and it changes the pH in the brain, and that's how it helps with memory. But the remainder of the treatments are treat the ancillary symptoms. They treat some of the associated symptoms, not the core symptoms of memory. So sleep maintenance is important, as I mentioned before. Well, I mean, it helps with memory, but it helps indirectly by helping sleep. Treatment of mood disorders helps by, to treat the mood disorder, you can help with the memory symptoms. Treatment of psychosis with dopamine blockers is, you needed. Dopamine blockers are the only medications that actually treat psychosis. Next slide. We have more. The list goes on. Treatment of agitation. Behavioral interventions are really important. Behavioral interventions can be helpful with psychosis as well, but behavioral interventions, it's important to find out why the person is agitated. So environmental manipulation can be helpful. I didn't mention earlier, but it comes up here. Treating someone's hearing deficits or visual deficits can help a lot with agitation, with dementia and agitation, because sometimes sensory input is not ideal. And if you can clarify the sensory input, it can help with core symptoms of dementia and with agitation. But if agitation occurs around meal times or around the sun going down, or if clothing is uncomfortable or something, if you can find out what that is, a lot of times environmental interventions can be helpful. But then some of these other behavioral interventions like exercise or music, pets or reminiscence, that's good. There are no FDA approved medications for agitation and dementia. So all medications that are used off-label. Citalopram is an antidepressant that's used for agitation. Memantine is, as I mentioned before, used for memory, but that's sometimes used for agitation. Trazodone is an antidepressant that's used for agitation, and carbamazepine and valproate are anticonvulsants that are used for agitation. So sometimes dopamine blockers are used for agitation as well. So we can go to the next slide. So why is it important to treat? Well, it's important to treat for the patient and because it decreases. I mean, I'll talk about this in the context of depression as an example, but late life depression leads to increased disability, reduced quality of life, but also to worse outcomes, worse medical outcomes. And while I talked earlier about people sometimes when they're depressed being less compliant with treatment or less compliant with medications, then that often leads to worse outcomes, which then in the long run leads to more frequent hospitalizations, longer hospital stays, and ultimately more medication use, and sometimes, worse outcome in the long run, even though they may be taking less medication in the short run. And then there's increased substance abuse. There's also pretty solid data showing that late life depression increases the risk of development of dementia. Some of the mechanism of that is not entirely clear, but it may have to do with inflammation, because there's a higher inflammatory state in depression, and that may have to do with the development of the increased risk of development of dementia. So next slide, please. Benefits to the caregiver network. Screening for caregiver burden and burnout. There are support options available for caregivers. There's respite care, support groups, the Alzheimer's Association, and online resources, and things like that it can be made available. It's important to screen for elder abuse, and with treatment, there's coordination of care, and there can be some help with making care decisions, medical decisions, and other care. And then planning for late life is important. The advance directive is when the patient discusses their wishes before it's needed, in advance of any untoward outcomes. So the patient can let the family or caregivers know what they want, what their wishes are. And while every eventuality can't be discussed, but if the patient can can express what they want to some degree. It does take a burden off the caregivers because then the caregiver, the patient designates a personal representative, and that representative then speaks for them if they're not able to speak for themselves. So the caregiver, the personal representative is communicating the patient's wishes, not actually making decisions. So it reduces the responsibility of the personal representative to make decisions, and they rather are just communicating the patient's wishes, which can be a relief. So it's a good thing to do if you can. Durable power of attorney is for can be for financial decisions and medical. So anyway, next slide, please. Family involvement. Family involvement is really important, and the role of the family does have to be determined by the patient, because any information about care, medical records, inviting the family into appointments, all that has to be authorized by the patient, because medical records and medical information is protected health information, and it is governed by confidentiality. But having said that, it's really useful to have family members come, especially for the initial consultation when history is being gathered, and with treatment along the way, because they're involved and it's important, and it's often very helpful. So with the consent of the patient, that's something that we often do. And when families are involved, it streamlines things to designate a contact person in the family. So I usually communicate directly with the contact person, and then that person then communicates with the rest of the family. That tends to make things a little more simple. If there are family issues that need to be addressed, family therapy can be arranged. But the exception to confidentiality there, I listed imminent danger to patient or others, public health threats, or certain subpoenas. Of course, that's rare. And of course, patients can direct me or the other doctors to collaborate with primary care physicians and neurologists and others as well. So that's the end. That's the end of my presentation. I certainly welcome your questions, and I hope that was helpful. Hello.
Thank you again for that presentation, Dr. Kerr. That was excellent. We actually do have quite a few questions, so I thought I'd just go in order and ask those questions for you. And so the first one is, do you see depression earlier for those who have early onset dementia and/or Alzheimer's?
Do I see depression earlier? I would say yes. I would say those conditions are associated with depression very frequently. Those are tough. Early onset Alzheimer's. Early onset Alzheimer's is a very tough condition. Yeah, and is often associated with depression. Yes.
The next question is, I saw that there is a new Alzheimer's medication that has hit the market. Does that seem to help?
Well, that is the hot topic because it came out last week. That is Aduhelm, And I'd much rather pronounce the trade name than the generic name, which is aducanumab. So I'm trying to pronounce that. Aduhelm is a monoclonal antibody, and it's the first medication that's been approved for Alzheimer's disease in 18 years. It works on the amyloid hypothesis, and the amyloid hypothesis is that amyloid plaques collect in the brain when tau proteins malfunction and form neurofibrillary tangles, which is probably more information than you really wanted to know. But what you need to know is that all Alzheimer's patients have amyloid, but not everybody who has amyloid has Alzheimer's symptoms. So Aduhelm prevents deposition of amyloid, but it's not clear that Aduhelm prevents Alzheimer's symptoms. So it prevents amyloid, but it's not clear that it prevents memory loss. And so this FDA approval is controversial. I mean, you might have also read that several FDA officials resigned over this thing being approved. So the FDA did ask for more studies, but it is out on the market, and it may prove to be, quite helpful, but it is a little early to say. It's for mild cognitive impairment, which you know what that is now, and it is for mild cases of Alzheimer's because they want to use it before the amyloid has been deposited. Because in advanced cases of Alzheimer's, the amyloid is already there, so the Aduhelm wouldn't do a lot. And so you have to have a PET scan to document amyloid. It's a once-a-month injectable, and it's $56,000 a year. And the potential, which I mean, if it helps Alzheimer's, that may be cost-effective. But the potential side effects are swelling of the brain and bleeding of the brain. And so there has to be close monitoring of this, which may mean MRIs, which is then another expense. So it's going to be interesting. Apparently there are 148 drugs being researched now for Alzheimer's, and 12% of them are amyloid hypothesis. So it's interesting, and it might prove to be quite helpful, but we need to know more. I think we have to see how much of this swelling and bleeding is going to be, significant, and we need to see how much it helps with the symptoms, not just reducing amyloid.
Perfect. Well, thank you for answering that. Somebody wrote in and said, can someone with a pacemaker have the magnetic treatment?
I believe they can, because someone with a pacemaker can have electroconvulsive therapy, and transcranial magnetic stimulation is a lot less voltage. So I would say I have not actually had anyone with a pacemaker have transcranial magnetic stimulation, but I know that people with pacemakers can have electroconvulsive therapy, which is much more voltage and much more invasive. And TMS is ECT light, so I would say 90% sure, yes. I would definitely contact the TMS folks, and I would definitely ask them, and I bet they'd say yes. Okay. I don't actually do it myself.
Okay. All right. This next question is heavily medical terminology based, so I'm gonna try. You mentioned the effectiveness of acetylchlorinase inhibitors is fairly limited.
Inhibitors, yes.
What is the effectiveness level of memantine and caprolidine?
Yes. Yes. Memantine is about the same as an acetylcholinesterase inhibitor. No, I mean, I tell patients this, none of them turn battleships around. I mean, none of these turn battleships around. They're modest. I mean, we don't have a blockbuster for Alzheimer's disease. We do not. I mean, I think this is why there's a lot of excitement about Aduhelm. You know, this is why the FDA pushed fast-tracked Aduhelm. You know, we can move a few points on a test and maybe we can improve function a little bit. We don't have, a lot of times we're treating the behavioral symptoms. We're trying to help with sleep. We're working with the environment. We're trying to, we're making sure that the hearing is good, the vision is good. You know, we're doing things, we're treating agitation. We're doing things. We can't stop the disease.
And then the last question is there any way to get a copy of the PowerPoint slides from today's presentation?
You're welcome to.
Okay.
Absolutely. I'm not sure how to do that in instrumental terms, but
we can send them out to all of the participants that have joined us this evening.
Yeah, that'd be great.
Okay, great. Thank you. And we actually just had one more question come in. I apologize. So the person who was asking about the pacemaker mentioned that people with pacemakers cannot have MRIs. So that was her question regarding the magnetic.
Oh, well, that's an interesting, yeah, well, yeah, because it's magnetic. Well, yes, interesting. Well, I would have to defer to the TMS people. Do you want to give me your name and number and I will talk to my TMS people and get back to you? I'd be delighted to do that.
I will be happy to give you her email address, Dr. Kerr.
Yeah,
I will send that to you after the presentation.
Sorry, I can't share that with the rest of the participants because that's a really good thought because it is, yeah, because an MRI, you can't get an MRI with a, but, yeah, interesting. Yeah, it's a good point. And I have not actually had anybody do that. Yeah, I will find out. I'll find out and get back to you.
All right, great. I will share their information or I can communicate to them for you. Yeah. Well, we thank you, Dr. Kerr. That's the end of all of our questions. We really appreciate you taking the time to join us today and, give our participants the opportunity to hear, more about dementia and depression and, how they coincide. So we really appreciate your time and we thank you and we hope to see you again soon.
Okay, my pleasure.
Thank you. Have a good evening.
Bye. Bye.
Thanks. Bye.